denk dat je niet zo vreselijk veel macht hebt om dingen anders te laten gaan. Het gebeurt gewoon.
Maar ja, ik ben wel blij dat ik gewoon nog leef natuurlijk.
On voit l'être aimé complètement distordu et il est là, il est plus là, mais en même temps il est là.
Quando hai alle spalle un dolore, una sofferenza del genere, apprezzi anche le piccole cose. Non è scontato niente, non è scontato che respiri, non è scontato che stai in piedi e cammini, puoi correre, non è scontato vedere il sole, non è scontato niente.
Bijna verdwaasd rond, in een trance rond. Maar ik moet zeggen, de zorg eromheen is wel heel erg goed. En ja, het was een heftige tijd, maar wel een mooie tijd.
Welke gevoelens ik heb ervaren. Ja, je bent ontzettend nauw betrokken bij mijn vrouw, wat die meemaakt. En je kunt daar niks mee, maar je moet er zelf mee uit de voeten. En je hebt wel het volle vertrouwen, dat had ik wel steeds.
Io sono un medico di terapia intensiva, non un rianimatore, nel senso che lavoro con i neonati, quindi mi occupo di tutt'altra di bambini molto molto piccoli, non faccio il loro stesso lavoro, però chiaramente il rapporto con i medici è stato condizionato anche dalla mia posizione. Tra l'altro sono dei colleghi perché sono nel mio stesso, quindi da una parte ero sicuramente facilitata nel comprendere razionalmente quello che stava succedendo, cioè non avevo bisogno dei lunghissimi colloqui perché mi spiegassero, per avere notizie cliniche, perché era più semplice riassumermi le cose. D'altra parte, dal punto di vista umano, dal punto di vista emotivo, questo non è servito a niente, anzi forse ha peggiorato le cose, perché sapevo cosa poteva sucedere e non volevo accettarlo.
Ahora lo que me motiva es mejorar la vida de la gente. Ya no es tanto la técnica, ¿no?, como cuando eres joven, porque llega un punto que la técnica es técnica y no tiene ningún secreto, sino las pequeñas cosas que pueden hacer que marcan la diferencia. El hablar con el paciente, con la familia, el hacer una educación sanitaria que nadie ha hecho hasta ese punto y tú no lo sabías porque dabas por hecho que lo habían hecho. Esas cosas son las que te motivan, el mejorar el cuidado del paciente.
Il faut faire du cas par cas, en fait. C'est primordial, parce que chaque histoire est différente. Et quand vous vous trouvez en tant que patient, en tant que famille de patients, dans cette situation, dans un univers où vous ne parlez pas cette langue-là, cette langue faite d'acronymes et de termes techniques que vous ne connaissez pas, quand vous vous retrouvez face au savoir et que du coup vous vous retrouvez impuissant, que vous vous retrouvez stupide, que vous vous retrouvez humilié, que vous vous retrouvez démuni, comment faire?
Jokainen lääkäri varmaan pelkää komplikaatiota tai jotakin, että mitään ei hiffaa jotain juttua, mitä olisi pitänyt hiffata, joskin siinäkin auttaa se, että harvoin tekee yksin koko päivää töitä. Nämä tuli nyt äkkiseltään mulle mieleen.
And what scares me is that making those decisions and making those wrong decisions and the realization that that decision in 3-4 weeks' time, where you end up having a patient who, in effect, can be crippled by life-sustaining therapy, which may not have been in their best interests or the family's best interests. And that still scares me. And I think it scares a lot of colleagues, but intensive care is much more multidisciplinary now, and I think that has helped our decision-making and has reduced that fear factor.
Honesty and humility go a long way. And most patients and relatives understand that we're also human and mistakes can happen and should be openly discussed.
Οι ασθενείς όμως έρχονται σε επαφή με εμάς, ιδιαίτερα αυτοί που βγαίνουν από το νοσοκομείο, πηγαίνουν σε κέντρα αποκατάστασης και ύστερα από πάρα πολύ καιρό έρχονται να μας συναντήσουν, γιατί ξέρουν τα πρόσωπά μας, τις φωνές μας, τον αγώνα που δίνουμε μέσα στο χώρο για να καταφέρουμε να τους σώσουμε, να επιβιώσουν και έρχονται να μας δουν, να μας γνωρίσουν από κοντά, να τους δούμε κι εμείς.
Together with my colleagues, in particular the nursing colleagues, we arranged a wedding for a patient who was at the end of his life and had decided to marry his long-term partner before he later died. And it was very moving to be part of this very special event in the intensive care unit.
It's a real privilege to be able to support a patient and their family through that, what I hope is the worst thing that ever happens to them in their lives, to be able to support them through that, hopefully to recovery, or to support them through managing a dignified death.
Il faut ramener la vie. Pourquoi est-ce que tout est si blanc et voire gris? Pourquoi est-ce que ce lino couine autant sous les crocs des médecins? C'est insoutenable. Pourquoi est-ce que tout est autant aseptisé? C'est pas 3 photos qui vont empêcher les gens de travailler. Moi, je pense que c'est important de ramener de la vie à cet endroit où on se trouve à la frontière au bord d'eux, on se trouve dans une espèce de no man's land où on sait pas sur quoi ça va déboucher, quoi.
La mia opinione della terapia intensiva è fantastica perché mi hanno salvato la vita e dopo 3 anni sono qui. Anche a un altro ospedale che mi hanno dato per morto, per fortuna sono arrivato in questa terapia intensiva e mi hanno salvato veramente la vita.
Solo belle cose possono uscire dalla mia bocca, ovviamente, perché senza di loro non sarei qui, ripeto, non sarei qui oggi.
Intensive care medicine allows me to learn something new every day. So every day I meet colleagues and I hear of their new technologies, new advances, and progress in their particular specialty. But most importantly, every day is a different day with new challenges, and I enjoy the interaction with my colleagues and most importantly with patients and their relatives. So it provides a great variety, it's different every day, and it's a specialty where progress is made on a regular basis.
Grazie perché mi hanno ricordato anche come si lavora. Cioè, io faccio questo mestiere, lo faccio da tanti anni, ci sono dei momenti in cui sei stanco, in cui hai le tue cose, nel senso che hai la tua vita, hai delle preoccupazioni, però io ero serena quando andavo via, non perché sapevo che non sarebbe morto, poteva morire, poteva star male, ma era nelle mani migliori. Sapevo che era nelle migliori mani e questo mi dava quel minimo di tranquillità che potevo cercare. È giusto che i bambini che mi vengono affidati e i genitori quando vanno a casa possono pensare la stessa cosa. Siamo nelle migliori mani, quindi dobbiamo sempre fare il meglio. Grazie a loro per esserlo il meglio.
Good afternoon. My name is Jean-Louis Vincent. I am professor of intensive care medicine at the University of Brussels, an intensivist in the Department of Intensive Care at the Erasmus University Hospital in Brussels. And I have the privilege to moderate this very interesting webinar on septic shock associated with COVID-19. It's a privilege for me to be here, and I'm looking forward to hearing the presentations by Professor Jean-Louis TEBOUL from Paris and Professor Ludhmila HAJJAR from Sao Paulo. They will introduce themselves in a moment, but I will only state that they are internationally recognized experts. So I think it will be a very good webinar, and I would like to thank from the outset, not only the European Society, of course, for allowing us to have these discussions, but also Amomed, which is the company that sponsored the webinar. So our intention is to focus on septic shock associated with COVID-19. We may raise the question, is it really septic shock? The answer is, yeah, it's septic shock due to a virus, at least initially, before any bacteria may come into play. But sepsis means a bad infection plus some organ dysfunction, and indeed, sepsis may be viral and septic shock may be viral. And a number of patients with COVID-19 may have organ dysfunction, not only of the lung, but also the other organs, and they may actually die of multiple organ failure. You may actually even wonder how people could die from respiratory failure if we have modern respirators, if we have ECMO available, we could keep patients alive with this form of support. So I had the opportunity to write a short paper on this in the Lancet recently, maybe 2 weeks ago, on how do patients die when they have COVID. And there are different ways of dying. It could be withholding life support, it could be withdrawing life support, but we know that many of these patients will develop multiple organ failure. Many of them will be a bit hypotensive, they will need some noradrenaline, the lactate level will be a bit high. So we will discuss the management of these patients with vasoactive agents, noradrenaline, dobutamine maybe if there is myocardial depression, maybe beta blocking agents if there is excessive tachycardia, which is not necessary. We will see the place of vasopressin. Interesting question too. And of course, we need to consider the right amount of fluids, because it appears that some of these patients are actually too fluid depleted as people are worrying about the lung condition and sometimes abusing of diuretics and restricting fluids too much. So we will speak about all these aspects. I will stop here and ask Jean-Louis TEBOUL to start with the initial approach with fluids and the initial vasopressor therapy, and then we will go on with Ludhmila HAJJAR with other forms of vasoactive drug support. So Jean-Louis, can you briefly introduce yourself and start your talk, please? Bienvenue.
Thank you very much, Jean-Louis. So I am Jean-Louis TEBOUL. I'm a professor of therapeutics and intensive care in Paris-Saclay University in Paris, France. I am very honored to be here and to present this lecture about hemodynamic management of patients with COVID-19. And I thank a lot the ESICM and also the Haemodynamic company for this invitation. I would like to first to say some words about my very good friend Wolfgang Huber, who passed away last week. He was a good friend, but he was also a very good doctor and a great scientist in the field of hemodynamics. And I dedicate this lecture to him. So my conflict of interest. So as you know, the main feature of COVID-19 is the presence of ARDS, essentially in ICU patients. In this study, published in the JAMA, the incidence of ARDS was 61%. But sometimes we have shock. In this study, it was 30% incidence rate for shock. In some other studies, maybe less, but around 20%. So the question we have to answer very frequently for this disease is the presence of hemodynamic instability or presence of shock. If there is no hemodynamic instability, there is no need of fluid administration, no need of other cardiovascular therapies. It is very simple. If yes, it could be different mechanisms. Could be vasoplegia, could be hypovolemia, could be right ventricular failure, also could be myocarditis. We have to exclude rapidly right ventricular failure. It could be due to ARDS-related pulmonary hypertension, but also mechanical ventilation-related pulmonary hypertension due to the presence of high transpulmonary pressure in this kind of patients with ARDS. And also, very frequently, the presence of pulmonary embolism and sometimes massive pulmonary embolism, which could be responsible for shock. So we have to discard this very quickly. And of course, we can suspect this by the presence of high CVP, which is frequent in this disease, and also, of course, the use of echocardiography as soon as possible and as much as possible. Also, we have to exclude myocarditis, which can result in cardiac arrhythmia, which can result in fulminant cardiac failure. And of course, we need ECG, cardiac biomarkers, echocardiography as soon as possible and as much as possible before maybe performing some more sophisticated technologies like magnetic resonance imaging for the heart. So I want to focus, of course, on hypovolemia at the early phase of the disease. Probably you know this new paper, the Surviving Sepsis Campaign Guidelines dedicated to the COVID-19, and the experts suggested using a conservative over a liberal fit strategy. We have to discuss this point because we know that COVID-19 is associated with hypovolemia very frequently, essentially at the admission time because of dehydration of the patient, maybe sometimes profound dehydration, and also the presence of sepsis.
TEBOUL. I hope we can come back very soon. Otherwise, I hope that Ludhmila is ready because we may have to shift to her. Ludhmila, would you be ready otherwise?
Yes, sure, Professor. I'm ready.
You are ready? Okay. So let's ask again for Jean-Louis once, twice, three times. Ah. I hear something? No? No? So do you think we should shift to Ludhmila? I think it's okay, there is no, it will be okay to return to these fundamental mechanisms and to fluid management. So Ludhmila, can you introduce yourself and start your aspects that you will deal with?
Yes.
Welcome.
Thank you, Professor. First of all, I'd like to thank all of you for this opportunity. It's really a pleasure to be here talking about such an interesting topic in a moment that the world is living one of the most challenging times of our history. Thank you very much, Professor Jean-Louis, Professor Jean-Louis TEBOUL, and all of the organizers who made it possible.
Yeah, okay, Ludmila.
Okay.
Yeah.
So
Go
let's
ahead.
talk about the hemodynamic management septic shock. As we can observe, this disease is characterized by an intense inflammatory response with activation of immune complexes, activation of endothelial with release of cytokines such as interleukin-1, 6, 8, and other mediators. 2 weeks or 3 weeks, we can observe an intense inflammatory response, which will lead to ARDS, cardiovascular dysfunction, and multiple organ failure. We can divide the disease in 3 stages. Stage 1 characterized by the viral response. Stage where we can see the inflammatory response mainly in the lung, when patients start to present dyspnea and we have the lung infiltrates. And the stage 3 is the phase where we can see an intense inflammatory response, where we characterize this disease by an intense hyperinflammation, and patients present elevated inflammatory and cardiac biomarkers, developing vasoplegic shock, mainly with different degrees of myocardial depression. We can share the phenotypes of shock in COVID-19 in 3 types. First of all, the vasoplegic shock with ARDS. Secondly, the vasoplegic shock with cardiac depression. And in less patients, we can observe the phenotype mainly with cardiac dysfunction, and these patients develop secondary vasodilation. The pathophysiology of septic shock involves hypovolemia, peripheral vascular dysfunction with hypotension, cardiac failure, and abnormalities in the distribution of blood flow. However, in COVID-19, we can also observe important influence of mechanical ventilation, once most of these patients with shock will be in invasive mechanical ventilation. We can see a high percentage of patients with cardiac injury, and also we have in the pathophysiology many signs that we have activation of thrombogenesis. This will ultimately lead to cell dysfunction. We can observe in these patients that about 40% of them will present any degree of heart dysfunction. These patients present high levels of troponin, and in the most severe cases, myocarditis, thrombosis, arrhythmias, and cardiac depression. These patients have laboratory abnormalities, such as high levels of cardiac markers, D-dimer, interleukin-6, ferritin, CRP, procalcitonin, and others. This will represent the biomarkers of shock, multiple organ failure, and a few patients will die because of intense inflammatory response and multiple organ failure. We can observe that these patients, they present direct myocardial injury and also the effects of the hyperinflammation. This, associated with hypoxemia, will increase the chances of these patients present cardiac injury, arrhythmias, acute coronary syndromes, and cardiac failure. As we can observe in these slides, all of these clinical presentations, they have a relation, a direct relation with sympathetic stimulation. Even the myocardial infarction risk the heart failure risk, and also the arrhythmias risk. Also, we can observe in these patients higher risk in occurrence of thrombosis in the pulmonary circulation and renal circulation, and also in cardiovascular circulation. And there is a direct interaction between inflammatory response and thrombosis. This will lead to multiple organ failure. As we know, in the treatment of the patients with septic shock, we should be fast and we should personalize the treatment, but aiming to improve oxygen delivery. And we know that as fast as possible, we should apply vasopressors if patient is hypotensive. And IO goals would be to optimize hemodynamic early in these patients, to avoid hypervolemia, as we have many patients with ARDS, with shock. We should try to avoid the compromise of gas exchange, to avoid the increasing energy demand, as the cardiovascular system is usually affected by this disease. We should try to mitigate the heart dysfunction, and ultimately we should try to optimize oxygen delivery. As Professor Jean-Louis has told a few years ago, we should try to assess in which phases my patient is. In the salvage, where we must obtain a minimal acceptable blood pressure, or in the optimization phases, where we should try to optimize cardiac output, SVO2, lactate, or in the stabilization, or in the weaning phases of the de-escalation. We should try to monitor these patients to assess response to therapy, as to assess adverse events of the therapy. As this patient is becoming more severely affected, we can increase the degree of monitoring. We start with echo, with lactate, with minimally invasive monitoring, with perfusion markers, and as these patients have profound acute circulatory failure with associated ARDS, we can increase the degree of monitoring. As Jean-Louis has told us, we have the Surviving Sepsis Campaign guidelines on the management of the COVID-19 patients. So they recommended that we should try to optimize the arterial pressure as fast as possible. And so they recommend that we should use norepinephrine as the first-line vasoactive agent. And if norepinephrine is not available, we suggest the use of either vasopressin or epinephrine as the first-line vasoactive agents. And they recommend that as a suggestion to add vasopressin as a second-line agent, over titrating norepinephrine dose. We know many adverse effects related to increased doses of norepinephrine. So, in a moderate quality of evidence, they suggest that we should add vasopressin as a second-line agent to decrease the needing of norepinephrine. They recommend against the use of dopamine, as we already do in septic shock patients, and they suggest to titrate vasoactive agents to target a mean arterial pressure of at least 60 to 65. For sure, we should personalize it, but these are the recommendations. So why should we consider decatecholaminization in a few patients? We know that many patients with shock develop refractory hypotension. At the same time, when we can decrease the norepinephrine needs or the catecholamine needs, we are avoiding increasing oxygen demand. We should try to avoid metabolic disorders, immune disturbances, decreased regional flow because of the excess of catecholamines. We should try to decrease excessive inflammation, pulmonary hypertension, atrial fibrillation, and maybe weakness, and maybe mortality. As we can observe in patients with cardiogenic shock, a recent meta-analysis showed that epinephrine increases mortality. And this might be related to the excessive release of catecholamine. When we see a recent meta-analysis that I have the pleasure to participate with the Canadian group, we can see that when we observe, when we analyze the association of vasopressin plus catecholamine, when we compare to the isolated use of catecholamine, to add vasopressin is associated with a decrease in the occurrence of atrial fibrillation, with a tendency of lower mortality, with a decrease in the needing of renal replacement therapy, at the costs of the increased rates of digital ischemia. We know, based on experimental studies, that vasopressin has not a profound effect in the vasoconstriction of pulmonary arteries. So this also would be very interesting in the setting of acute respiratory distress syndrome to avoid pulmonary vasoconstriction. We can see also in this experimental model that vasopressin was associated with increased survival in a rat model of pulmonary hypertension when we compare with phenylephrine or with norepinephrine. In this recent paper that has just came out, we can observe that the ICU acquired weakness that we are worried about this in this time, it's associated, it has a profound effect of the use of vasoactive medication in the increased occurrence of ICU acquired weakness. As higher the doses of norepinephrine, the higher the chance of the patients develop ICU acquired weakness. So this can hypothesize that we should try to decrease the needing of these drugs in the setting of COVID-19. Of course, independently of the use of the drug, we should try to get our goal of mean arterial pressure as fast as possible, because the lower the time that we acquire, the higher is the survival probability of the septic shock patients. And maybe we could discuss about the broad spectrum of vasopressors. Low doses of norepinephrine added to vasopressin, because here we should try to emphasize that we have a complex pathophysiology of shock in these patients with multiple defects. And so we would correct them without increasing the norepinephrine doses. We had already talked about the higher incidence of cardiovascular dysfunction in these patients. In the cases of shock with evidence of cardiac dysfunction, they suggest to add dobutamine over increasing the norepinephrine dose. Dobutamine can increase cardiac output, can recruit capillaries, can increase oxygen delivery. And also, as a weak recommendation, they suggest in the cases of refractory shock that we should try to use low doses of corticosteroids. Also, in the cases of more severe cases of cardiogenic shock, of the cardiac dysfunction, we should try also to optimize hemodynamic, but in the case of refractoriness, we should try to insert circulatory supports, both pulmonary and cardiac, independent of the phenotype of the shock. When we have isolated respiratory failure, our support will be a VV ECMO. In the cases of the right ventricle dysfunction, we could try to use a single cannula right ventricle assistance or a VV ECMO plus a right ventricle impeller. And in the cases of a biventricular dysfunction with left ventricular dysfunction, maybe we try to use a VA ECMO as the support of choice in these patients. I could not finish my presentation without talking about atrial fibrillation in these patients. We know that in general, in sepsis, atrial fibrillation is associated with higher incidency of mortality. As we know, the prevalence of tachyarrhythmias in these patients is high. About 40 to 50% of patients will present atrial fibrillation or any kind of ventricular arrhythmia. And this is mainly due to sympathetic overactivation based on the cytokine storm with activation of inflammatory mediators and also potentialized by drugs that we usually use in the management of these patients. Nowadays, people use amiodarone in the ICU, but we have lots of worrisome about the negative inotropic effects of amiodarone and also the lung effects of the use of amiodarone. So maybe to decrease the overactivation of catecholamine, to decrease the inflammation, we should try to think in a personalized way to indicate a beta blocker in these patients. Landiolol is an injectable ultra-short-acting beta blocker indicated for heart rate control of atrial fibrillation in this setting. Landiolol is associated with a significant reduced risk of hypotension and decreased negative hynotropic effects. As we can see, there are a few papers with this drug in the setting of shock, in the setting of critically ill patients. Here, we can compare amiodarone with landiolol, and we can see that we have a higher proportion of patients converting the rhythm to sinus rhythm when they use landiolol. When we compare the adverse effects between the drugs, we can observe that landiolol did not result in any case of bradycardia and did not increase the rates of hypotension. So we can consider this drug in the management of patients with atrial fibrillation with the overactivation of sympathetic values. So in conclusion, we know that the pathophysiology of COVID-19 involves active inflammation, endothelial dysfunction, thrombogenesis, and a high incidence of myocardial injury. We should take into account that the hemodynamic therapy should be tailored according to the phenotype. But we should try to avoid catecholaminergic stress because of the pathophysiology of this syndrome. And of course, further studies are needed. Thank you very much.
Talk, and indeed it emphasizes the risks associated with any intervention, and perhaps it's valuable to combine agents perhaps at lower doses so as to minimize the untoward effect. We will go back in a moment to the doses of vasopressin, when you start, do you use beta blocking agents primarily to prevent atrial fibrillation or to treat it, or in other cases? Let's keep these questions. We have one very quick question from the audience because you mentioned procalcitonin, and this person would like to know how you use procalcitonin. Is it increased in COVID-19, or do you use it primarily to detect a superimposed bacterial infection? How do you use procalcitonin levels in this context?
Thank you very much for the question. Procalcitonin levels are increased in COVID-19. We know this based on the previous studies, such as CRP, interleukin-6, and also we have increased levels of procalcitonin. So in our clinical practice, we will see how it will range, how it will trend along the disease. Because in the admission, we usually take a baseline procalcitonin, and during the clinical evolution of the patient, an increased level of procalcitonin may be directed related, for example, to the high incidence or the higher probability of a bacterial infection. But of course, it's already increased in COVID-19 patients.
Okay, very good. Thank you very much, Ludmila. Jean-Louis TEBOUL is back with us after this technical problem. Jean-Louis, Ludmila also reviewed a little bit the pathophysiology of shock in COVID-19 patients. Maybe you couldn't see it, but you can move on now and return to the initial hemodynamic management with fluids and noradrenaline. Jean-Louis, welcome back.
Okay, thank you. Can you hear me, Jean-Louis?
Yes.
Yes, okay. Okay, so I restart at the level of hypovolemia. And again, I repeat that the suggestion of the SSC guidelines dedicated to COVID is to use a conservative over a liberal fluid strategy. So I want to just to remind that hypovolemia is a very frequent feature in COVID-19 due to dehydration, due to the cascades of mediators resulting in hypovolemia, but also we have to consider the presence of coagulopathy with the risk of thrombosis in this disease, and of course, the presence of ARDS, which is mainly characterized by the endothelial cell damage. And this can result into different anomalies. First, the increase in the lung capillary leakage, and this results in increased permeability, pulmonary edema, and also VQ mismatch, which is directly related to anomalies of the perfusion of the lungs. Of course, pulmonary edema can result in VQ mismatch, and also thrombosis of the pulmonary microvessels also can result in VQ mismatch, and this eventually leads to severe hypoxemia. But we have to remember that hypovolemia can be responsible for low blood flow, multiple organ failure, and also it can favor the risk of thrombosis, which also can result in multiple organ failure at the level of the tissues. And what about PVO2? Because if you have a low blood flow, you should have a low PVO2. And sometimes when you have a high pulmonary shunt, the low PVO2 can be responsible for hypoxemia. So we have to keep this in mind. So when you give fluids, if you give fluids, there is a therapeutic conflict because you can, of course, increase the risk of pulmonary edema due to the lung capillary leakage and increase the risk of severe hypoxemia. But on the other hand, you can correct the low blood flow and you can either prevent or limit the risk of multiple organ failure, the risk of thrombosis, and the low PVO2 effect. So finally, you can have a balance between the benefits and the risk of fluid administration. And we have to assess this, we have to predict this at the bedside before giving fluid to these patients. So we have to assess the benefit-risk ratio. The benefit can be given by the degree of fluid responsiveness, and the risk, which is a worsening of lung edema, by some markers of lung edema. Regarding the degree of fluid responsiveness, we know that not every patient in the ICU is fluid responsive. And in this analysis of the literature we did with Frank Micha in the past, only 52% of patients were fluid responders, meaning that 48% did not respond to fluid administration. And we know that these patients with COVID-19 are likely hypertensive with cardiovascular disease, or sometimes could have some cardiomyopathy, so they are not always fluid responsive. And we have to keep this in mind. And if you want to assess fluid responsiveness, all the international societies now recommend using dynamic over static variables to predict fluid responsiveness. You know, we have two categories of dynamic indices of fluid responsiveness. We have the heart-lung interaction indices, which are usable in patients who receive mechanical ventilation, and we have passive-leg rising, which can be used in any situation. You know that the most popular indices for heart-lung interaction indices are pulse pressure variation and stroke volume variation. And you know that when you have a high pulse pressure variation, high PPV, we can assume that the heart of the patient is fluid responsive and the patient will respond to fluid administration later on. And if you have the opposite, a low pulse pressure variation, you can assume the opposite, that the patient is not fluid responsive. Of course, we know that at the bedside, we have many limitations of pulse pressure variation or stroke volume variation. And therefore, we have to look at other tests which have been developed recently. You know, the end expiratory occlusion test, which is very simple to perform because you have just to interrupt the ventilator for 15 seconds, around 15 seconds, and you have to look at the changes in cardiac output in response to this maneuver. And with Xavier Monet and others in the past, we showed that patients who will respond to fluid administration, the blue circles, also increase cardiac output during the end expiratory occlusion, while the patient who will not respond to fluid administration, the red circles, did not increase their cardiac output in response to the end expiratory occlusion. So it is easy to discriminate between responders and non-responders just by doing this test. But we have a very low threshold value, 5%, so we need a very precise and real-time cardiac output monitoring device. And in ARDS patients with Xavier Monet and others, we also showed that this test is very good compared to pulse pressure variation to predict fluid responsiveness. Also, we have tidal volume challenge. We know that many of these patients with COVID-19 ARDS are ventilated with low tidal volume, I mean around 6 ml per kilogram. And you know that pulse pressure variation and stroke volume variation in this situation are not good enough to predict fluid responsiveness with a high rate of false negative. So we can develop another idea. And with Sheila Mailatra and colleagues from Mumbai, India, we develop a new test which consists in increasing tidal volume from 6 to 8 ml per kilogram transiently around 1 minute, and to look at the changes in pulse pressure variation. For 6 ml per kilogram, the predictive value of PPV was not very good, as you can see on this slide, and the area under the rocker was not very good. It was better when we increased tidal volume at 8 ml per kilogram, but it was far better if we look at the changes in pulse pressure variation from 6 to 8 ml per kilogram. And we found a cutoff of 3.5%. Meaning, in other words, it means that if you measure a PPV of 7% in low tidal volume ventilation, and you increase tidal volume from 6 to 8 ml per kilogram, and if now PPV is 11%, you can assume that the patient will respond to fluid administration. If PPV increases from 7 to 9%, you can assume the opposite. So it is very easy to do, very helpful in the absence of cardiac output monitoring. Of course, you have the passive laxing test, which is a test which mimics fluid challenge, but no drop of fluid is infused, but you need a real-time cardiac output monitoring device to assess the effects of this test. And in this meta-analysis, we performed with Xavier Monet and Paul Merrick in 21 clinical studies and almost 1,000 patients. We observed that the changes in cardiac output during passive leg raising was a very good predictor of fluid responsiveness, with a global summary area under the rocker of 0.95, which is good, and a threshold value of 10%. And it worked very well in patients with ARDS. As you can see on this slide, it was far better than PPV in this study we performed in our institution with Xavier Monet and others. The denominator of the benefit-risk ratio also should be assessed, and we should use some markers of pulmonary edema. So what to choose? Can we choose PEOP, the wedge pressure, using a Swan-Ganz catheter? It's not sure. If you look at this study by Sandrine Boussa and co-workers, there is no relationship between PEOP on the x-axis and extravascular lung water on the y-axis. For example, a value of PEOP of 12 liters of mercury can be associated with very low lung water or very high lung water value. So it's not possible to rely on PEOP to assess the risk of pulmonary edema. It is better to directly estimate extravascular lung water using some devices which are called transpulmonary thermodilation devices, and they can provide a value of extravascular lung water with a quantitative measure of lung edema. And in the past, with Mathieu Josiac and Xavier Monet and others, we showed that the maximal value of extravascular lung water during the stay of the patient with ARDS was an independent predictor of mortality. So it is very interesting to look at. It is also interesting to look at the pulmonary vascular permeability index, PVPI, which is also provided by these transpulmonary thermodilation devices. And it is a very good quantitative marker of lung capillary leak, the permeability. And again, in this study, we showed that the maximal value of PVPI was an independent factor associated with mortality. So it makes sense to look at this value. So these devices, the transpulmonary thermodilation devices, are very useful for guiding fluid management, especially in patients with ARDS and septic shock, which is sometimes the case in COVID-19, because they can very well assess the fluid infusion benefit risk ratio, PPV, SVV, PLR, and expercussion for the prediction of fluid responsiveness, so assessment of the numerator, the benefit, and lung water and PVPI for the denominator, for the tolerance and the risk of fluid administration. So it is very easy to make the decision to start, to continue, or to stop fluid infusion. And the cardiovascular section of the ESICM published a paper some years ago for patients with shock and ARDS. We recommended the use of advanced hemodynamic monitoring technologies like transpulmonary thermodilation systems or PA catheter, essentially in the case of right ventricular dysfunction. This slide shows some very recent data we collected in 30 patients with COVID-19 ARDS in our institution. And I thank a lot Dr. Ruishi and Professor Xavier Monet for this very rapid analysis of the data. And on this slide, you have the lowest PF ratio of our patients, and we subdivided according to the Berlin definition in severe ARDS, in moderate ARDS, in mild ARDS, and we measured at the same time we measured the extracellular lung water. The green bar is for the normal lung water, the black bar for the very high values of lung water. And if we look at the patients with very severe ARDS, PF ratio lower than 100, we can see that some patients had a very high value of lung water. And of course, in these patients, fluid infusion is very risky, even in case of shock, in case of fluid responsiveness. But in some other patients...
Jean-Louis, I'm a bit concerned about the time. We will now need to move to noradrenaline. We must have some time for questions.
Okay,
please.
I move. Just to emphasize that it is important to measure lung water, not only PF ratio. Okay, I move to noradrenaline. Vasoplasia at the beginning could be due to use of high dose of sedative drugs, of course, because we need to ventilate these patients with a high dose of sedative drugs, as you know, and also associated septic shock. And we rely on the value of diastolic arterial pressure, low DAP, to evaluate this, the degree of vasoplasia. A low DAP is a good marker of decreased vascular tone. So in this case, we can consider vasopressors. And in this paper published recently in a paper from China, we can see that in 30%, 35% of cases, vasopressors are used, and essentially at the beginning, before fluids, to counteract the effect of sedative drugs. And as said by Ludhmila, the surviving sepsis campaign guidelines dedicated to COVID-19 also recommend or suggest the use of norepinephrine as in the case of classical septic shock. But they also recommend or suggest to target an MAP between 60 and 65 meters of mercury rather than higher MAP targets. And I think that this recommendation could be questioned because it is assumed that one size fits all, the same target for everyone. Of course, it is probably not the case in a case of history of chronic hypertension, for example, and you remember this multi-center randomized controlled trial conducted in France by Pierre Asfar and others. In this paper in septic shock patients, we compared two strategies, one with a MAP target of 65-70, one with a MAP target of 80-85. We did not find any difference in mortality, but we found better kidney function with a high MAP target in patients with chronic hypertension. And probably this is due to the fact that in case of history of chronic hypertension, we have a shift of to the right of the autoregulation curve with the organ blood flow on the y-axis and mean arterial pressure on the x-axis. And for example, a value of 65 meters of mercury, which is good for patients with no prior hypertension, could be not enough for patients with chronic hypertension, and we have to target a higher MAP in this case. Another condition which is commonly observed in COVID-19 patients is high CVP because of right ventricular dysfunction or simply because of the use of high levels of PEEP. And even if PEEP is not 100% transmitted to CVP, some transmitted values can increase the CVP value, and therefore we can have a high CVP. And in this situation, we cannot neglect CVP because, as you know, the organ perfusion pressure is not only MAP. It is a difference of MAP and the downstream pressure, which is roughly reflected by CVP for most vital organs. So the difference between MAP and CVP is very important to take into account. This is the mean perfusion pressure. And Marius Osterman and co-workers showed that mean perfusion pressure, but not MAP, was an independent factor associated with acute kidney injury progression. And they found that the MPP of 60 meters of mercury was found as a cutoff. So if you target a MAP of 60 or 65, maybe it's not enough in case of high CVP, and you have to increase the target to keep the gradient for perfusion. So my conclusion is that for hemodynamic management, we have to personalize the assessment and the decision. In terms of fluid management, we can consider the decision of fluid infusion in cases of hemodynamic instability with organ failures. Benefits assessed by fluid responsiveness test higher than the risk assessed by the lung tolerance indices. In terms of decision of fluid depletion, which can consider it in cases of severe hypoxemia plus fluid unresponsiveness, and at best, if you can measure it, the presence of high extracellular water. In terms of vasoplegia, the decision of norepinephrine administration should be made in case of low diastolic pressure, and this even at the early phase. And the target, the MAP target, should be individualized, especially in this kind of patient with chronic hypertension, who are very common for COVID-19, and in case of high CVP. And you always listen to the lecture of Professor Ludhmila HAJJAR in terms of for the place of other vasoactive agents. Don't forget to exclude massive embolism or myocarditis as potential causes of shock, and there is a major class for echocardiography. I would like to thank you very much for your attention.
Thank you very much, Jean-Louis. That's a very good talk on fluids and noradrenaline. And indeed, I was very pleased that you emphasized that giving vasopressors without paying attention to adequate fluid therapy can be very dangerous. You mentioned the word hemodynamic instability. I'm a bit worried about this. There was an editorial in Critical Care on this recently, because sometimes the physicians consider that their patient is very stable when the patient is on high doses of vasopressors, but they didn't have to change the dose of vasopressors. So the patient has been very stable on high doses of vasopressors. But we know what you mean. And you emphasize that excessive fluid administration in COVID can, of course, be harmful, especially when ARDS is present, if we can speak about ARDS. But restrictive fluid strategy could be really dangerous. I had another conversation today about the kidney in COVID and the risks of hypoperfusion of the kidney in patients who receive a lot of diuretics because people are concerned about the lungs. So it's more a conservative fluid strategy that we should aim at rather than a restrictive fluid strategy. Do you agree with this distinction, Jean-Louis?
I fully agree. I fully agree. I put hemodynamic instability just to make you reacting that's it. But when I put hemodynamic instability, I mean shock or peripheral hypoperfusion, tissue hypoperfusion, etc. That's just for you to react.
We know, we know we understand each other definitely. So the other important point is that we need to individualize our therapies. It's not a mean arterial pressure of 65 for everybody. As you indicated, sometimes we need to go for a higher mean arterial pressure level, especially in those patients with previous hypertension. Ludmila, do you agree with this personalized approach?
Sure, Professor Jean-Louis. We know already a few trials that did not lead to any conclusion about different levels of mean arterial pressure. Of course, we know that at least 65, but we should tailor therapy according to perfusion markers, according to previous history of hypertension, so we should individualize at bedside.
Well, perhaps in some patients, we may go to a lower level when they are chronically somewhat hypotensive. There was a very nice paper in the Blue Journal on this recently, showing that we sometimes overtreat some patients who may be very happy with a lower blood pressure than the one we try to achieve. So we need to personalize our therapies. But the question, Ludmila, is when would you start vasopressin? Would you start when the patient is on relatively high doses of norepinephrine, or would you start it earlier? You indicated that it may be an option to start with vasopressin even before using an alpha adrenergic agent like noradrenaline. What do you think? And then I will ask the same question to Jean-Louis.
In a few years, in a paper that we published together with the help of Professor Jean-Louis Vincent, we showed that in cardiac surgery, vasopressin was superior as the first drug, as monotherapy, when we compared to norepinephrine in decreasing a combined endpoint, mainly due to a positive effect in acute kidney injury. So,
but some people may say this is not after cardiac surgery, this is COVID-19. What would you reply?
Talking about COVID-19, we are in a setting of high incidence of cardiac injury, of sympathetic overactivation. So I think that we have a rationale, we don't have studies, but we have a rationale to start with vasopressin, or at least to add as early as possible vasopressin when we go titrating norepinephrine. I would not wait for the refractory shock. This cocktail of vasopressors, I think that it has a rationale because we should try to fix all the defects of vasoplegic shock. Maybe in COVID-19, we could take into account the cardiac injury and the sympathetic overactivation to choose early the vasopressin, or as monotherapy, or as an additional drug to low doses of norepinephrine.
Okay, thank you. Jean-Louis, would you agree? Do you see it differently?
No, until recently, we have no access to vasopressin in my country. So we use norepinephrine, and that's it, and we increase the dose of norepinephrine. But pharmacologically speaking, and it is, I think it is more, how to say, suitable to add vasopressin earlier than we do right now. So we use high dose of vasopressin.
Seems that we lost Jean-Louis again. Jean-Louis TEBOUL. We lost him. Okay. So Ludmila, we will continue, both of us. And I'd like to ask you, as I mentioned before, and that will be my last question on vasopressin, but would you use fixed doses or do you sometimes titrate it a bit?
We titrate the doses. We know that the most efficacy doses of vasopressin in these studies varies between 0.03 units per minute until 0.06 units per minute. So in my clinical practice, we start with 0.03, and in many patients, it's enough. And in the case of no response, we can increase the doses up to 0.05 until 0.06 units per minute.
All right. And someone in the audience asks, what about inotropic agents? Perhaps first dobutamine, and then you may say a word about milrinone and levosimendan. So let's start with dobutamine or an inotropic agent in general.
In the case of COVID-19, we have, in a few cases, a profound vasodilation. So in this setting, dobutamine is the safest drug to avoid the occurrence of hypotension, which is a common effect of levosimendan and of milrinone. In the cases of we don't have shock, milrinone or levosimendan may be good drugs of choice in the setting of pulmonary hypertension, right ventricle dysfunction, but without shock. In the presence of shock, dobutamine is the safest drug.
Okay, but now, how can we go to the other side? Because you mentioned beta-blocking agents earlier, and indeed we could mention landiolol, for instance. But how do you decide to go for dobutamine, and how do you decide to go for the opposite, for a beta-blocking agent?
Okay, in the phases of hemodynamic resuscitation, in the cases of patients, it still persists with signs of tissue hypoxia, with signs of hypoperfusion. In the setting of cardiac dysfunction, I go through dobutamine. In the cases of my patient is stable, he is already resuscitated, and he presents with atrial fibrillation or tachycardia, so I go to landiolol, for example, or any other beta blocker that I have experience or that I'm safe. But when we look to landiolol, we are looking for a drug which is not associated, or that it does not look like to be associated with hemodynamic instability.
Very good. Yeah. So indeed, you are warning us that we should not give beta-blocking agents just because there is tachycardia, because if there is heart failure associated with it, it may not be the best choice. Is it true?
Perfect.
Ludmila? No?
Yeah.
You agree. Okay. Okay, and the last, I see here that a person in the audience asks, and we should have done it, when you give vasopressin and noradrenaline, and when the patient improves, would you stop vasopressin first, or would you stop noradrenaline first?
Very good question. There is a recent paper published in Critical Care last year that they have driven the nurses to decrease either norepinephrine or vasopressin. And in that paper, the winning vasopressin was worse. In the case of the winning vasopressin first, patients needed to increase norepinephrine needs. But in our clinical practice, what we do is to personalize, because lots of patients will win vasopressin first, and lots of patients will win norepinephrine. But when we look to the clinical effect, when I start vasopressin, my patient goes to decrease the levels of norepinephrine, when we get titrating norepinephrine to low doses, I start to decrease vasopressin.
Very good, thank you. Jean-Louis, welcome back, my good friend. We have some technical problems this afternoon, but that can happen. Our time is over, but perhaps you have a last comment to make, your last conclusion that you would like to bring about the hemodynamic management of these COVID patients with septic shock.
No, again, my message is to individualize the management and the decision, not to follow the same track for every patient, but to try to personalize.
Yeah, personalized therapies and evaluate the effects of our therapies. I think that's what Ludmila insisted on as well. So we could have a number of other questions. Our questions about albumin, about PEEP, about a lot of questions, but I'm afraid our time is over. So I would like to thank you for your participation, and of course thank Amomed for their support. We had interesting discussions, and these will of course continue on, but for today we have to bring it to an end. So many thanks to all of you. Take care of you and take care of your patients. Bye-bye.
Thank you. Bye-bye.